professor, physician, epidemiologist. I am Dr. Sri Banerjee. Hello, everyone. I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. I'm proud to announce today that myself and my previous chair, Dr. Ray Panis, from my dissertation committee from a while back, worked together. Along with other collaborators such as John Hute, Mariangela Sierra, and Dr. Michael Zeroni, we worked on this to kind of demonstrate in one way, one particular way, demonstrate the connection between chronic viruses and chronic diseases. So the idea is this. Infectious diseases and chronic diseases traditionally have been treated separately. But can we find a common denominator? That's one question that we're trying to figure out. But more importantly, if we do find that common denominator, can we actually measure it and study it? Because if we do, if the answer is yes to that question, then we can actually track disease and disease severity before it takes place and before it becomes a really devastating condition. So that's the premise behind this work. Inflammatory biomarkers of chronic disease associated with chronic viruses, evidence from the NHANES study. So let's get started. So chronic viruses, of course, are known to be associated with cardiovascular disease, but you may ask yourself, why? Why would viruses lead to heart disease? Well, we know about inflammation within the heart. We know about bacterial diseases, even dental work seeding into the heart, causing infection. So that's there. So pathophysiologically, we know infectious diseases, and when we were studying COVID, of course, that had a direct effect on the heart as well. And additionally, there's overall increased burden within the rest of your body because it's trying to fight off a virus. So if you have any sort of congestive heart failure or anything, that just exacerbates any sort of pre-existing chronic conditions, which was why it was so important, not only during COVID-19, but any chronic virus pandemic, to be able to be looking at these pathophysiological conditions. Then you cannot ignore medication side effects. Of course, triple therapy, AZT, all these things were good for HIV. And are good, making HIV now no longer a death sentence, but more importantly, more of a chronic disease in and of itself. So the next question, most logical question is C-reactive protein, something that is produced within the liver, an inflammatory biomarker, which is oftentimes associated with chronic diseases. I showed this in my dissertation, and many people have actually shown this. Can this be a tangible and under-recognized biomarker that can provide the linkage between chronic disease and infectious disease? That's what we're after. So here is a map. Let's take a break and look at a visual to kind of break up all the monotony of the words and you listening to me speak. But here is the HIV. This is 2021. We're not looking at the 80s. 2021 current. Per 100,000 HIV prevalence all across the United States. And I should see no dark blue within this map. And the reality is, when you look at this map, there's dark blue areas. There's areas where higher HIV prevalence is there. And the reality of the matter is areas with higher HIV prevalence. These are also areas where there are lower socioeconomic status, areas of need, and areas of social deprivation. Um, so you might ask yourself, this is of course presented nicely in different places. Why create a map when there's similar map? Well, I had to create this map because there were specific. If you click on this map within the website, within the web domain, this is located, and there's specific interactive dashboards that I've provided in order to give adequate details at the zip code level. That is what is unique with my map and you might not be able to see in others. So that showed me one thing. That showed us one thing. We really needed to dig deeper. We needed to look in and see what is going on. Why are there very spatial differences going on in the rates of HIV and other chronic viruses like hepatitis B and C? So we looked at individual level data. That was group level data that has its limitations. We then dig deeper into National Health and Nutrition Examination Survey, cross-sectional survey, done on a non-institutionalized population in the United States by both the Centers for Disease Control, but more broadly, the National Center for Health Statistics. And I've talked to them many times. A very, very robust sort of data set. If you haven't used it before, please do. All patients with the nationally representative NHANES study, if they were 20 years or older, and if they said that, yes, they do have HIV, hepatitis B, or hepatitis C, or a combination of any of them, then they were included within the analysis. And pretty soon you'll see the distribution, the exact distribution, because I'll share that with you. So of course, sample weights, sampling, these are very important tenets in statistics. And as you will see, this was actually equivalent to about 4.7 million people. The number of people, not exactly, but representative of that many people within the United States. So, as with any sort of analysis, you start with kind of frequency distribution. Then we went into understanding bivariate analysis. And important bivariate analyses are, of course, chi-square, but also simple regression is considered bivariate. But then when you expand out into multivariable logistic regression, we wanted to see if there was a relationship between cardiovascular biomarker like C-reactive protein and chronic viruses. And of course, as in all analyses, all missing variables were excluded. So we wanted to see if there was balanced sort of sample distribution. There's slightly higher rates of females than males, and kind of a good to acknowledge. And also, there's some additional findings. So 64.7% males versus 35.3% females. And this was representative, as I said, 2.7 million people within the United States. So let's look at the distribution. So here's the viral distribution. And this is important because we're looking at the distribution of the different viruses. And about a fifth, we're looking at about a fifth just having HIV within the sample. A quarter had just hepatitis B, but half had just hepatitis C, and then 2% had a combination. So that's the distribution of the viruses within the sample. So according to the multivariable findings, this is where it gets really important because you get to see in individuals that are infected, that have had this chronic virus long term, what are the effects of, and so when you have elevated C-reactive protein, these individuals are 7.4 times higher likely to develop cardiovascular disease than individuals that didn't have elevated C-reactive protein. Now, if we controlled for, you can say maybe it's coming from another infection that they have that you can track of. Well, if you keep track of the current infections and control for that and other cardiovascular disease risk factors, then it still is 9 times higher to develop cardiovascular disease if you have elevated inflammatory biomarkers than individuals that don't have that inflammatory biomarker. So these are very important findings, and I'll tell you why. So let's just take a step back here and take a look at all the things that C-reactive protein, all the devastation that C-reactive protein causes within the body. So I want to show you, of course, the prothrombotic state. This, of course, doesn't help in the development of strokes and other things, but also the activation of the complement cascade. This was really important in the pathophysiological development of COVID, and also the vascular wall damage, the RAS activation, the plaque remodeling, oxidative stress, endothelial dysfunction, oxidized LDL. All these things are not only wreaking havoc within the vessels of the heart, but they're creating clots, they're creating oxidative stress, they're creating a milieu and environment that is not conducive for good health. And this is what really causes poor outcomes when you have inflammatory biomarkers, which are indicative of, of kind of chronic viruses. And these viruses are somehow still continue to produce some of these inflammatory biomarkers. So it's really important that we keep a keen eye on these inflammatory biomarkers. So in conclusion, we found a consistent and significant relationship between high sensitivity C-reactive protein levels and patients with CVD. And this is specifically, we looked at, of course, people with chronic viruses. So C-reactive protein may be used as an effective prognostic biomarker to predict the occurrence of CVD before it occurs. I mean, and it proves to be fatal. Imagine the power of that, the ability to predict the next potential MI or CHF exacerbation, especially in individuals that have chronic viruses and HIV. Of course, more longitudinal studies are needed. This is not longitudinal. This is more cross-sectional to really know how inflammation plays a role in the heart. And the reason, additionally, let me cue you on a clue here. If we know that these inflammatory biomarkers are actually elevated, there are actually currently biologic agents, chimeric agents, which are very effective against inflammation. So there's actually therapies that could be delaying poor outcomes. And the solutions are there, and they are there now, I'm happy to say. So it's important. So it's really important. I'm going to leave you with this, that we understand the role of inflammation. I would argue we should map out inflammation within the geospatial context. And inflammation is very much closely connected to the social determinants of health. So I would argue that we should create inflammatory determinants of health, because the inflammation at the end is kind of the marker that is indicative of social factors. It's indicative of viruses, and in many ways, chronic diseases as well. So if we address inflammation, then we are engaging in work and social determinants of health and social change. So here are my references. And if you have any additional questions in this area, don't hesitate to contact me. I hope this has provided you with some really good insights that you can take into the clinic, take into practice, even in teaching students and understanding the depth of inflammation. And again, I appreciate the invitation to talk at this prestigious conference and presentation. Thank you for listening.